Good day. My name is Anene Ukaigwe. I'm a recently graduated structural heart disease fellow at the Minneapolis Heart Institute, and I'll be talking about transcatheter treatment of rheumatic mitral valve disease without balloon valvuloplasty as part of the novel mitral valve case series at CVI Digital 2020. I have no disclosures. So a case is 7-year-old female recurrent heart failure hospitalizations due to rheumatic mitral stenosis and regurgitation that is also associated with severe functional tricuspid regurgitation. Prior to planned elective surgical mitral valve replacement and tricuspid valve repair, she decompensated to cardiogenic shock of multiple organ dysfunction, and she was then transferred to our institution for evaluation and treatment. At this point, she was deemed to have a prohibitive risk for surgery, and therefore transcatheter therapy options were pursued. These are her baseline images. On the top two left pictures, we see that the characteristic doming of the anterior mitral leaflet consistent with rheumatic mitral stenosis as well as eccentric mitral regurgitation. Her main gradient at this point was 6 millimeters of mercury, and the 3D image in the middle lower panel shows features consistent with the fish mouth deformity of rheumatic mitral valve disease. The two images on the right, top and bottom, show the severe tricuspid regurgitation that was associated with this. For her, then, the plan was staged transcatheter tricuspid valve repair and then evaluation for transcatheter mitral valve replacement. The tricuspid valve was successfully addressed with repair. This was completed with the G4 clips, and we discussed this in our initial experience with transcatheter repair with the G4 clip section of this conference. Invasive hemodynamics with direct left atrial pressure and left ventricular pressure monitoring showed a mean gradient of 9 millimeters of mercury at a heart rate of 80 beats per minute, consistent with at least moderate mitral stenosis. So approximately 3 months after the successful transcatheter tricuspid valve repair, she was evaluated for transcatheter mitral valve replacement with a Tendyne valve. And this image shows that she was anatomically suitable because there was a suitable size. There was adequate new LVOT as predicted from this CT planning, and there were no significant challenges seen with transapical access. The procedure was then completed about 6 months after she had undergone the transcatheter tricuspid valve repair. And we see here on the left the medial to lateral direction of the valve after it's been inserted through the transapical access. And on the right side is the anterior posterior trajectory of the same valve after it's inserted. This after the valve is inserted, further deployment is guided 3D echocardiogram, and we see that the A2 portion of the Tendyne valve is pointed towards the commissure, and therefore the whole valve system is rotated such that that A2 portion is pointing towards the A2 portion of the mitral valve, i.e. towards the aortic valve in the surgeon's view. After the position is deemed satisfactory, the valve is then released and assessed for paravalvular leak, mitral valve leaflet function, and adequate tension is applied to ensure that the valve is anchored, and then through the apical pad that tension is maintained and transferred to the. So these images are after the valve has been deployed and anchored to the apex. There was no evidence of LVOT obstruction by echocardiographic derived gradients. And the mean mitral gradient of the newly deployed valve was 2 millimeters of mercury. There was no paravalvular regurgitation. The valve was seen to be well seated on fluoroscopy, as seen on the left side images. So surgical mitral valve therapies are typically used when percutaneous balloon mitral valvuloplasty is anatomically not feasible. And initial experience with transcatheter mitral valve replacement with the Tendyne prosthesis for mitral stenosis has been associated with mitral undercalcification, which helps with the valve anchoring. And in this patient population, this technology has shown excellent outcomes. This case is an initial one that describes safe and efficacious use of Tendyne with rheumatic mitral valve stenosis, and that has been successful.